Bore da chi gyd, a croeso i'r bwrdd iechyd prifysgol Aneurin Bevan. Welcome to today's meeting. Sorry, we're just slightly late, but the traffic, I think, has defeated a great many of us in getting here today. And welcome to our guests, Vivek and Star, who are on the programme for the development of independent members, and our colleagues from psychology and child and adolescent psychology, from whom we will hear later. We've had one apology from Tracy Daskovich, who is not able to be here, but I think the rest of us are, which is good. Thank you for making the effort and battling through the floods. Are there any declarations of interest for noting today? No? Okay. If we go to the consent agenda business, you will see that the issues that are in the consent agenda. Does any member wish to bring forward to the main agenda anything on the consent agenda for discussion? Or are we content with taking those as they stand at the moment? They mostly contained sealed documents, draft minutes and the updates. Are we happy with that? Okay, thank you. Can we go on to the Chair's paper report, which I've just lost. There we are, find it in a minute. Apart from my normal meetings, which seem to have been interminable this time, and my visits, which I've enjoyed very much, I have had to attend a number of national committees and regional committees. I've had 3 meetings of the Care Action Committee, this committee that has been established by the Cabinet Secretaries successive to look at health and care interface issues, and which launched what is called the 50-day challenge last month. We had to send in our return by the 11th, which we did, and I'm very pleased to say, well, poor girl, Jenny is what is called the accountable officer for the Regional Partnership Board for Gwent. We have pointed out that you can't have accountable officers for non-statutory bodies, but that's what they're calling them. And they're supposed to speak on behalf of the RPB and coordinate action required of the RPB, an onerous task. But anyway, we were able to fill in the 50-day challenge paper in time, given so little notice. Yeah. I have asked for and I will circulate the paper that we have sent in and the definitions of what we're supposed to be adjudged against. Now, the principle is that by the, I think it's the end of November, we're supposed to have reduced length of stay delays by a considerable amount. Is it 25%? Yeah. Yes. And as you know from the returns, the length of stay is going up. And by the 31st of December, we are supposed to have reduced the number of delayed transfers of care altogether. Now, this is an aim that all of us wish to pursue. A great deal of effort has gone in from the whole of the partnership, statutory, all the statutory authorities and the third sector, to trying to achieve better flow in hospitals. And you will have seen the numbers of projects that we have instituted, apart from these 10 best practice issues in Aneurin Bevan, in order to alleviate the position, working very closely in an integrated way with our partners in local government. Nevertheless, despite the enormous efforts that have been made and the real progress that has been made, the numbers stay a bit stuck at about 230. And nobody wants anybody to stay in hospital any longer than is at all necessary because of deconditioning and all the issues that go with that. Nevertheless, we did ask for some evidence that the officials will have provided to find out on the basis of what did they think this is achievable. We await the answer. We are learning from each other. There was a very helpful presentation from West Wales yesterday, Jenny and I heard, and Jenny is going to pursue that option of a different integrated model. So the good thing is we are all learning from each other. Everybody has got to showcase something at each meeting, and I think it's us next. Yeah, I think. So that is very useful, but I am concerned that the aspirations might not be met, and I don't want that to undermine the extremely good work that is going on in each of the health boards with their partners in local government, because I think great strides have been made in keeping people safely and well looked after in their own homes. The people who are coming into hospital that we're finding very difficult to discharge are hugely complicated, as you know, and as the practitioners will know. And we have to make sure at the base of all of this that our patients remain optimised and very safe indeed in our care. But there is this push to do that. So that has basically been the discussion there. And some of it is very helpful, isn't it, Jenny? It's really helpful. So we will learn from each other. I've had 2 meetings of the RPB leaders. They are concerned about the real stresses in social care. I have to say that in the Gwent area, one of our problems was domiciliary care, and the local authorities have made a great impact on being able to secure more domiciliary care workers and providers, and they have made an enormous difference, as you will see from our returns, for which we're very grateful. But there is no doubt, with the numbers of people who have to be assessed, who have to be maintained in their own homes, a huge stress on social care. So we have supported the local authorities in making a valid case for an improvement in that area. And that's really what has caused the greatest consternation to the Regional Partnership Board leaders. We've also had 2 meetings of performance management for chairs held by the Cabinet Secretary. The focus of these meetings is on waiting times, particularly cancer, and of course delayed discharges. And what the Cabinet Secretary does, this was started by the former Cabinet Secretary, now First Minister, is make sure that the boards are effectively assessing and scrutinising the bids that are coming in and the action being taken by the health bodies, and it's all health boards, in terms of improving the waiting times for patients and managing the waiting in the most effective way possible, particularly for cancer. You will see from our performance reports how we are performing. We have some way to go, but I'm relieved to say that in this health board, where we've said we'd do something, we've actually achieved it, rather than being aspirational and then disappointed. So I feel that the planning is at least very solid in the way in which we can seek to achieve the goals. They're not the most comfortable meeting I ever attend, really, and I don't think chairs are usually held to account for planned care improvements, but nevertheless, again, it has allowed the chairs and their organisations, and particularly the chief executives, to work very collectively and again to learn from each other, because everybody is having the same sort of problems, and there is a great deal more regional work, particularly in the southeast, that's really making a difference now, which would, I don't think, have been possible a couple of years ago. So those are quite interesting meetings. I have also met David Sloman at his request, who is the new Ministerial Advisory Group Chair on Performance and Productivity, and have invited him to the next Chairs meeting so he can explain precisely what their targets will be, what they're going to be interested in, and how they would wish us to respond. There's an eminent bunch on this Ministerial Advisory Group, mostly from England, some from GIRFT, and we have made good use of GIRFT now. So that is fine, and he will, I'm sure, be helpful to us. We've had quite a good reputation in England. I've met the Cabinet Secretary and Chairs together about innovation and improvement, so again a drive to doing things differently. And the Cabinet Secretary has visited us twice in the last 2 months and has come to YYF to see the new breast centre and went to Neville Hall to see where we were going to put the new ophthalmic centre in the suite at the back. And I have to say, he is most engaged with the staff, and I think gains quite a lot from those meetings. The chairs have met twice as well, and they have covered the same things that I've discussed. The RPB met last week, or was it this week? I don't know. No, it was last week, and discussed the winter plan. And I attended the meeting, well, not in person, but virtually, to launch the Accountability and Performance and Culture Report, which has been produced by Plaid using the colleagues from the Nuffield Trust, which really very much reflects the Ministerial Advisory Group's findings on the same. So it's been a very busy period, really, in addition to everything else that we are doing. But I am glad to see far more cooperation throughout Wales now to try and defeat the problems that beset us all. And that, I think, has been an extremely useful step forward in terms of the quality and outcomes for patients, which is the most important thing of all. So has anybody any questions? No? Thank you. Nicola.
Yeah, thanks, Chair. And I suppose my report follows on quite nicely from the context you've set from a Chair's perspective. And is a hugely busy, challenging time for the teams across the organisation. And we particularly look to how we organise ourselves over the next few months to focus on the really kind of big issues for us at an organisational level. Those three being very much the winter preparation and the plan, the delivering the ministerial priorities and particularly plan care as the Chair set out, and delivering on our financial plan as well. They are kind of, in addition to our business as usual, are where we put in extra effort at an organisational level. And all of these feature on the agenda today, which we'll talk about in more detail. But at a very high level, and on delivering the ministerial priorities, you will be aware there was originally £28 million announced from Welsh Government to target the priorities around plan care, particularly 104-week waiters, diagnostics, and some additional funding for CAMS as well. I think I'll be more detailed, but we secured over £5 million for orthopaedics and diagnostics to help us get to the 104-week wait and the 8 weeks for diagnostics, which we're really pleased to receive, really grateful, and working really hard to make sure we can deliver on those commitments by the end of March. We've still got some outstanding discussions with Welsh Government on ENT to be able to deliver 104 weeks for ENT, and we've been successful in securing around 7 million for the region for ophthalmology. So a huge backlog, particularly around cataracts, and we're working really hard. And Rob and the team as well in terms of looking at what outsourcing, and we'll pick that up into the plan care item. A huge amount of work going into that, in addition to delivering to the plan that we already committed to. There was an additional 22 million has been communicated as going to be available, but we're not aware at this point what that means for us. But we are working closely with Welsh Government and have submitted a number of opportunities to do further work. So we look forward to seeing what that might mean for us. Cancer, obviously, and mental health are key areas where we've got improvements, trajectories, and we've got a huge focus as well for the remainder of this year and over the winter period. Urgent emergency care, our big focus is the winter plan, as Chair mentioned in terms of the 50-day challenge. This has been a huge amount of work. Lots of it is work we're already doing with partners, but really does kind of focus the mind in terms of where the big opportunities are. And I think the big challenge for us is understanding what impact that can have quickly in the winter to help inform our winter plan. I know we've got that on the agenda later, and informing the capacity that we think we need as a health board to put in alongside these broader range of opportunities, which hopefully will reduce the number of delayed discharges across the system. Also a big focus on vaccinations. This is a huge part of the winter programme. We are seeing generally a reduction in take-up of vaccinations. So we really do need to continue to push hard with our staff and our communities around vaccination take-up, which is a huge component part around protection over the winter. The focus on the financial plan continues. We picked this up through the financial plan. The financial report about significant increases in drugs across the board, which is challenging our financial plan. But we need to keep really focused on our savings opportunities and any other opportunities we can to mitigate those type of risks. On a positive note, we've been really successful in securing additional capital. In the September board, we brought the MRI. We've secured the capital for the second MRI at the Grange, which is fantastic. Secured capital for the discharge line, which helps the revenue position. And successful in securing some additional funding the Welsh Government given for discretionary, which will help us address some of the risks that are sitting on our capital risk register. So really positive news from a capital perspective. So in amongst all that planning, the last few weeks has seen us face some significant challenges. We had a couple of weeks where we had about 5 IT outages, pretty much as a result of some BT national work that impacted on us locally. I know Paul has been working with Welsh Government and with BT around future mitigation because it's caused huge disruption for the teams on the ground. And then, unfortunately, both of our CT scanners at the Grange went down last week, which is really unfortunate, but put us into a critical incident state for 2 days. But the teams, worked exceptionally hard to mitigate the risk, and we did have support from Cwmtach, Morgannwg and Cardiff, but pretty much managed most of it internally, and they were back up and running within about 36 hours, but huge disruption for the teams, but huge effort. It continued to amaze me how much everyone steps up. And then just to add to where we dealt with the floods over the weekend and the challenges that presented in terms of staff getting to work and us being able to get to certain patients who may have been affected. But again, huge partnership efforts with our partners in local authorities, police, fire and rescue and others. So been a challenging couple of weeks in terms of some emergency issues we've had to deal with alongside a very busy period. So just to finish on a high note, I've had the pleasure of attending the nursing conference and the healthcare support worker conference over the last, the healthcare support worker one was last Friday. Fantastic events, bringing some of that profession together and celebrating some of the great work they're doing, and huge energy in the room, which is great. And also got the pleasure of attending the NHS Wales Awards and the Royal College of Nursing Awards last week, where we had a number of our individuals and teams as finalists in both of those events. So that was great to be part of, and important to focus and remember the great work that many of our staff are doing to continue to improve amongst keeping the day job going. So thank you. Thanks, Chair.
Thank you. Any questions to Nicola? No, thank you. I might go on to the patient experience and public engagement, and I'm very pleased to welcome to today's meeting our team from Child and Adolescent Psychology, Dr. Jennifer McElwee, the consultant child psychologist, Mike Charles, the assistant psychologist, Lucy Bennett Downs, who's the patient carer peer mentor, and Emma Alm, the patient carer. Thank you very much. And you're going to talk about patient experience for the children.
Where would you like us to stand?
Wherever you fancy.
All right. So yeah, my name's Jenny McElwee. I'm the psychology lead for children with additional needs. Do you guys want to say who you are?
Right, so I'm Mike Charles. I'm an assistant psychologist working within the CANS pathway.
And I'm Lucy, I'm a parent carer peer mentor, so I have a little girl with Down syndrome and I bring my lived experience to a post within the children and family psychology.
Hello, I'm Emma Alm. I'm a parent carer. These are my beautiful children. This is Logan, my son, who's now 13, and my daughter, Shelby, who's got Down syndrome, which is why I came to be in touch with the service. Nice to see you all.
Okay. And today I'm going to very briefly do a bit of a context, give you a bit of context, and then we're going to go on to a video of Mike and Emma and Lucy talking about some of the work that they've been doing. And we'd really welcome comments and thoughts and ideas afterwards if we've got time. We'll see how we go. Okay, so just to say that today we're talking about children's rights in particular and how that kind of interfaces with participation within the work that we're doing. So children's rights approach means that organisations will prioritise children's rights in their work with children and families to improve children's lives. And for me, having worked in the Health Board for just 6 years now, I've seen lots of examples of that happening, different forums that mean that children's rights are really being thought about. And you can see this is the kind of cycle that we talk about, where you start with that context of equality and non-discrimination and accountability, and that leads to participation, which empowers children and their families, and embedding children's rights. Next slide, please. I just thought it was important to pause to say, why is it important to take a children's rights approach? So we've just got a couple of slides here. The first one just saying, well, we all have human rights, which include rights to influence our own goals and our own care. But also it's important, particularly with the children that we're talking about, to think about what the children actually need to learn about the right to make choices. Often the children that we're talking about, perhaps they communicate in ways other than language, and they have people that care for them and want the best for them, but often do a lot of things for them. So when we work with children, we have young people's groups, the first thing we often need to do is to teach them that they do have a choice, that they have a voice. So that's really important. It's all of our rights. It's enshrined in law and policy, as I'm sure you're all aware. So yes, it increases participation and empowers children, because they know themselves the best, and they also have some really clear ideas about what is helpful and not helpful. And actually it really improves care. So it supports collaboration and shared decision making. So services are more responsive, safe, personalised, effective and efficient. And hopefully when you watch the video, you'll see these guys talking about that a bit. Again, if we go to the next slide, just really wanting to kind of emphasise that point, the children that we work with. So for example, I can think of a parent that I worked with who had 3 children, and one of her children has additional needs. And when she goes out into the community, often people will say hello to her and her other children, but not the child with additional needs. So, but actually interaction with others allows us to construct our world and sense of self. It's really, really important to have that interaction. And then we, in our work, can really see the difference that makes. It's not just about saying what we think, it's about being genuinely listened to and taken seriously by the people we interact with. And for me, that's what participation is about. Okay, I think I'm really done with that. So yes, when we think about embedding children's rights in the work that we do, we think about these different levels. So yes, of course, we think about how patients affect their own care, impact their own care. But actually, it's really important, we think, for children, young people and their families to be involved in service development. And again, you guys will talk a bit about that. And training and research. We regularly have people involved. And also the other bit there, I guess, is in things like staff recruitment. So really making sure that the voice is there in all those different levels, and community and culture. So sometimes children and families will come to see us with perhaps what might be described as a mental health problem, but actually what we're seeing is that there are cultural discourses around what it means to be a child with additional needs, which means perhaps they're being excluded in different ways. And it's actually more of a social conversation that we're having rather than a mental health conversation. Okay. Slide, please. So just because these guys talk about this in the video, I'm going to give you a couple of examples of the ways that what this might look like in our work. So first of all, when we think about young people's participation in interviews, what we were finding was that we were having interviews, we were having young people and parents who could express themselves verbally and interact with people coming for interviews. But we realise there's a big cohort of children that we work with who don't express themselves verbally. So how do we get a sense of the people coming in and how they, whether they're going to be interacting, how they're going to be interacting with the children that we work with? So we've come up, the group of us have come up with, but very much drawing on Oti and Shelby, your two little ones, when they were tiny, they were kind of 3 and 5 or something. So before they were communicating using language, with a way of understanding that interaction. So we use what we call observable indicators. So we were liaising with our colleagues, for example, our speech and language therapy colleagues. What is it that shows that there's an engagement going on? So the kind of things we were talking about was smiling, eye contact, whether the child is initiating interaction, whether they're following the candidate and copying them, engaged body language, and then that specific signs of the child's engagement. So I think Otis was around whether she started singing Old MacDonald.
Very much.
If she got going on that one, it meant that she really liked this candidate. So we use that, and there's a wider framework with other things in, but we thought that was a good example of how we're engaging with young people, hopefully meaningfully. It feels meaningful. Certainly I love my team that I work with, that we've used this method to interview them. Next slide, please. Just to say the parent carer peer mentors, I did notice this morning that there's quotes on there that are the same and they shouldn't be the same, so I apologise for that. But yes, so Lucy is one of our parent carer peer mentors. It's not always easy having a parent carer peer mentor in the team, I have to say, because you're a point of connection for parents, but you amplify the voices of parents and carers, and that means that keeps us to task very, very well. And yeah, you're not afraid, are you, to
I
challenge
don't tend
me?
to hold back.
Yeah, yeah. And that really helps us to keep families and young people totally at the centre. And it also really empowers family. And that idea of a bridge that we have, sometimes it can be that families are saying, we've had, there's a new research coming out about service-induced trauma, where families, and we get this such a lot with the families that we work with, where they've just had, from birth pretty much, series of really difficult situations in interactions with services, which means that when they come to us, they're very wary of engaging. And again, our parent carer peer mentors can just go out and say, look, I'm kind of working for them and it's all right, you know, and have that kind of discussion and that thinking and engagement with them. And then next slide. So just wanting to highlight, I think this might have been on the brief, this is something called early positive approaches to support, again, which you guys talk about. So what we find with the children that we come to, at the point that they come to us often, they're showing very, very big behaviours that might be causing placement breakdowns, very, very expensive out-of-county placements. But what we can see is that often the real basics, the fundamentals of our lives are not in place for these children. So we think about things like, are these children having positive social interactions? Do they have support to communicate what they need? Are they participating in meaningful activity? Do they have consistent and predictable environments? Relationships, on it goes. These kind of things that perhaps might seem a bit kind of straightforward, but actually often the children we're working with don't have these things. And what EPATS does is that it brings parents together, it connects them together, and it gives them really useful information about how to support their child, with the idea being that if you can do that when children are younger, then when the children get older, parents feel more empowered, A, to reach out when they need to, but B, that they have this information about how to support their child. So I think that's it for the slides. So we're on to the video.
thank you. Aren't you lucky to work in such a fantastic and a really excellent field? And thank you very much. That was really, really great. Right, any questions?
It's a comment more than a question. And I mean, to me, this is an absolute win-win, isn't it? Because at the end of the day, I think, you know, we know that for children who can't communicate in a kind of way in which the public expect them to, that there's a frustration with that then often leads to the kind of behavioural issues and not cooperating because of that frustration. And to be able to find something to unlock that frustration so that children's voices can be heard, I think is just amazing. And so it's good for you as a clinician, isn't it? And then it's good for parents, and it's good for families and siblings and schoolmates and society in general. So it's just, I just wanted to comment and say that I thought it was great.
Thank you. James.
It was amazing and really thought-provoking. Thank you. Can I ask what we do when children begin to get to adolescence, when they naturally, as part of development, want to decouple from the people who they rely on absolutely for their care, and how do we allow children who communicate differently to develop their own sense of self and autonomy that's part of people's rights?
Really, really happy for me to start answering. You might jump in. It's made me think about lots of things. One of the things that I've noticed in Gwent in particular is the importance of giving children information. So thinking about growing up, relationships and sex is really, really important. And it can be that people will want to protect the children that we're talking about and the adolescents that we're talking about, but actually it's really important that they have information appropriate to their developmental level that allows them to make choices and support to do that, to make choices in a safe way, because otherwise you will have the behaviours that you see, but the child just won't know what's inappropriate or not inappropriate, for example. So there's that's really important. And then the other thing, the schools in Gwent, the special schools in Gwent are great, really good. And I think that move into that more independent living is really, really crucial. The schools are the really, really crucial part of that. So we're fortunate because there are 5 main special schools. There's lots of specialist resource bases, but 5 special schools. It means that we know them. We can connect with them. You were talking about multi-agency working earlier, and it's absolutely vital with the children we're talking about to have that, so that we can work together to think about those things.
And do you still get a sense, though, that when people transition from children's into adult services, it feels like falling off a cliff for the parents? I mean, it's the thing that always... I used to work with adolescents in my own clinical practice and saw the harm that can cause in the service transition. I mean, how do we manage that here?
Yes, it's enormous, and I know that I know what's happening, you know, in regards to my teams and the way that they've been working on transition. And I think one of the key things for me is working with families from the age at least of 14, so that you have that sense of planning and you have the time to think about what's happening and bring the young person into it. And for me, when I've seen it work not so well is when you get to 17 and a half and nothing's happened. So that's where I would hope that's where we're trying to work towards that.
I think it would be really helpful to have more transitional support for the whole family. As you said, I think for parents, my children are now, well, my eldest is 26, so we've gone through that period of having lots and lots of support, and then all of a sudden they turn 18 and then there's nothing. And I think for us as parents, I think that can be quite challenging, because then there's nothing, but you've still got a significant caring role with your child who's now an adult. But that support just isn't available anymore. So it can be quite a challenge for families when they get to that point.
Just add on to that as well, with regards to transition, Shelby is due to go to comprehensive school now. I've been looking into provision for that. And I have found, as a parent, you've got to do a lot of the work yourself. That's the thing, because so I'm hoping she will secure a place there. But again, with regards to her transition when she gets that older, again, already myself, I thought about Shelby absolutely loves babies, she loves children. So I've been to, there's a local play group attached to her primary school there, and I've already spoken to the lady who owns that and said, could she volunteer with you when she's older, or it could even be on a paid premise, but just for her to be doing something and give her a sense of self-worth, because I think they would benefit from her and she would benefit from them. It would be two-way, because she's amazing with children.
I think it's also really important that we don't see our kids and young people as other.
Yeah.
You know, they are just kids and young people as well. So it's, you know, my daughter, I can interact with her like I would any other 8-year-old, because she is an 8-year-old. Her extra chromosome doesn't define who she is. It's just something she also has. It's really, I think we have to, it's society's eye that has to change in the way that we approach our kids and young people. And I think that's one of the major hurdles that we have to jump really and understand. And once we are a sound community together, it's not that threat of, oh, here is other, how will they comprehend, how will they understand? And that will take that vulnerability out of them as well, because they are just us. I mean, you have to think for our kids as well. People with DS have only stepped out into society. This is kind of second cusp of third generation mixing among us. I mean, I find that awful, but I was kind of unaware of that until I was in it. And I think that we all have to just open our eyes to the community that's around us and that we can learn and grow from, really.
Yeah. Jenny?
I think it's really important that we hear the voice of children and their families, particularly children who have additional learning needs. And I think it's been fantastic that you've been able to come today and to talk about your experience, because we can only improve if we learn from that experience. And, you know, you shouldn't have to struggle. The services should be able to wrap around you in a way that really supports you. And I know the peer mentor roles are really important because they bring that voice, and it's really important that at this level we hear your voice and your struggles. If I was asked to ask you, if you could ask for one thing from us as a health board, what would it be?
An easy system to navigate through, one that holds us, that sees our young people and children as an individual, so that we don't slot in to fit the services. As you said, that the services wrap around the needs of our children. So the needs of our young people come first.
Thank you. Helen, Nicola and Penny.
Thank you. It's obviously very inspiring, excellent survey. I just wonder, how do you ensure that the families that need to be part of this actually get linked in and get the benefit from your peer support and mentorship? Because it's obviously crucial, but there must be people. How do you ensure that those people who need it actually access it or know how to access it? It's a bit linked in with what Jenny was talking about, really. I mean, is there a referral system, or is it you just, as you know, when a baby is born with Down syndrome, is one of the special needs, so they automatically get linked? But there must be children out there that may not.
They automatically get linked. They don't automatically get linked. Even with a clear diagnosis, the system was a tough one for us to navigate, and continues to be, because these transitions come up, so it's a new hurdle that we have to jump. But I will go over to services and referrals to you.
So for us, the key, as is very well known, is early intervention. And I guess that's part of the reason why we're coming here today, is to say EPATs at the minute we run 2 groups, so a maximum of 20 parents can get EPATs. But it's very easy to do, so it could be much more than that, and I think that would help. I think it's about linking in early. So, for example, we've just set up a new pathway with the neonatal physios in NICU, and we offer something called Time to Pause, which is literally just an hour and a half with parents where they're able to reflect on their experiences. But they also get to hear about some of these services. So getting in there early, like you say, it's not everywhere. Things like we're hoping to train the health visitors, for example. It's about getting out there. I manage the Portage, the child development advisors, so they tend to see most of the children with developmental delay. So again, linking them with Lucy very closely. But there are always the gaps and places, but yeah, very much trying to think early. And when I came into the health board, there wasn't any early intervention specifically thinking about the emotional well-being of children with additional needs. And so that's what through RIF funding, it's still temporary, but RIF funding, we've got this early intervention, and really hoping that will impact as much as we can.
I think the power of the CDAs I don't want to speak for you, but I know that we've had conversations about when the Portage, or now Child Development Advisors, came into our lives. I didn't even know it was a service that was offered. My health visitor didn't say that to me. I found out through an independent charity that works with families with kids with DS. But when they arrived, it was astonishing because she saw the promise in my child. I hadn't particularly seen anybody look at my child in that way other than us and family and close friends, some of them not even. I mean, but she was inspirational and she empowered us as a family, but she also just signposted. So she held us, she answered all of our questions if she didn't know the answers to those questions. She showed which services were out there, what we ought to do next. She helped with transition into nursery. The CDA service is an astonishing service, and one that needs more promoting, needs more funding, because that's how you get to our kids with that early intervention.
Thank you. Yeah, thank you all. It's, I'm a huge supporter of lived experience and peer support in all fields. So I think it's so powerful for people who've been through that. So, thank you personally for everything you're contributing. And I suppose my question links a little bit to Helen's. So not every child has got the benefit of parents like yourselves who are passionate and are out there fighting for them. And we know there'll be some, as you talked about, some of those basics that we assume might be in place and not. And I'm just wondering how we reach out to some of those children and their rights where they possibly haven't got the parental support and guidance that, we've seen here today. And how do we, as you said, identify those and then bring them in to see how we can make sure those kind of essential requirements are in place. So it's that part of recognising there's a multi-agency working around that as well, but just wondered what your thoughts are, recognising, starting with those who are keen and willing is probably where we need to start, but children's rights for people who haven't got the parental support is a worry as well.
Definitely a worry. I guess in addition to what we kind of already said, the other thing I was thinking about was the importance of our links with the early years teams in the local authority. Yeah. So we do a lot of work with them, the Flying Start teams. Another key role that we have in our services, we have somebody who is positive behaviour support is a well-known kind of model that we use, which links with all the things that were on the slide there. And we have a PBS practitioner who is specifically there for strategic thinking. So she does a lot of training and mentoring. And we were able to get some funding in to get key, what I would call practice leaders, trained in PBS. So we now have, for example, in Monmouthshire, we have a social worker and educational psychologist who are both trained to diploma level in PBS, and they are able then to cascade information and training. And in other areas, we've got other things going on. So it's the EPATS feels very, very crucial. The links, multi-agency links with early years, but also having that shared sense of understanding, which we're doing through creating these practice leaders and then, special interest groups and mentorships and everything that create those links.
Penny?
Yeah, thank you. It's a really interesting presentation, so thank you. My interest is in transition after education. I used to work in a college that had a fantastic proactive department with students with learning disabilities, where integration was key throughout the college. So I know about, the opportunities into that area, but after that, you say you have a child at 26. I wonder what happened after the education.
Not a lot, to be honest. I mean, they were able to manage. They did go to university. They went to University of South Wales and stayed in halls. So they managed that really well, I think. But there was a lot of structure and there was a lot of support around it. And actually, for us as parents, that we had to hold a lot of that. Once they finished that, once they had to come back home, I think it was really challenging for us. I mean, they lost their independence because they developed that, and then they became reliant on us again. And we've just recently managed to get them a flat where they're starting to develop that again. But it's difficult for that because they're much, I hate the word higher function, but they're much more able. So they are able to cope with those things with support, with our support. The challenge, I think, is that for a lot of families that parents aren't able to offer that or to that degree. As you said, in other cases where parents aren't able to support that, then you've got children or adults, then young adults sort of really struggling, and then become reliant on services to support that. So it's not an easy process.
And what about employment?
They're not in an employer. Their mental health, when they left university, their mental health became really bad as well. They left university, unfortunately, at the beginning of COVID. So there wasn't a lot of services or any opportunities for them to seek real employment during that time. And then mental health just dipped and dipped. And as a result of that, they've just not felt able to sort of go into work. They have done volunteering. They've worked at a charity shop on and off over the years, but nothing where they're actually earning any money.
Thank you.
Just to add to that and add to what Lucy was saying, I guess, when what we talk about is visibility and celebration in that way of trying to, rather than having a norm that's like this, to really increase the sense of what a norm is. And so I think, we obviously set ourselves high tasks, lots of enormous tasks, but that outside circle then becomes really, really important about how we allow people with additional needs to be part of our local communities, which then allows for those opportunities to be linking in rather than always leaning on services as well. It's how to do that. At all those different levels.
Any further questions or comments? Rob?
I just want to say thank you. It sounds amazing service. Wish you all the best for the future. And so I'm the finance director here. I'll be looking into some of the funding sources potential for this.
Yes, I'd be glad
Thank
if
you
you
very
would.
much.
Thank you, Rob.
There's a lady by here. Question.
Hi. I'm a learning disability nurse by background myself, and it's really lovely to hear some of the work that you've been actually doing. But I just wondered in terms of the engagement and making those reasonable adjustments for parents from ethnic minorities and actually making sure that visibility of the services are there in terms of making sure that the language that they can actually understand, and all the other parents who are neurodivergent, and how do they actually sort of know and actually access those services as well?
Really so important. There's some work being done in England at the minute, and the figures around people who come from an ethnically minoritised background and have a learning disability are absolutely shocking. The age of death is something like 50 or something. It's much lower than other people, and so it's something that's absolutely in my mind. And again, how do we do that in natural human ways without too much of a policy? Do you know what I mean? So we're very much thinking about that in the minute. We don't have any easy answers, but it's something, it's definitely a context that feels very, very live at the minute. So yeah, thank you for raising it.
Lisa?
Hi, thank you for that. That was really inspirational. I just wanted to flag really, my name's Lisa and I work for Llais, and our key role is very much around making sure the voice of individuals, families and communities are heard, and your experiences shape health and social care services. And I wanted to flag, I'm not sure if you're aware, but we're currently live with our child to adult transition survey, and we are carrying out a number of focus groups and are keen to really listen and hear your experiences so we can share with our health and social care colleagues around making changes. So if you are interested in sharing your experience with us, either go on our website or drop me a note, and I'll be keen to pick it up with you on a one-to-one. So thank you for that today.
Thank you, Lisa. Any further comments or questions? Can I just thank you very much for coming in this morning and exemplifying how really we can make a big difference to individuals within our communities in the best way. There are issues that concern me in your presentation and the whole thing about how comprehensive is this service, what about transition, and of course securing the funding as Rob suggested, and for Rob to say he'd like to, oh hello, this is amazing, this is great, but you know, and the fact that referral is not automatic is a big concern. So I think we need to take these steps with you to consolidate the service, and for goodness sake, if this is funded by RIF, please ensure you have an absolutely rock solid, wonderful evaluation, because we're going to have to make a really good case for all the schemes that have been so successful through RIF in order to secure resources from the Welsh Government for the future. They will be looking for really good evidence, and this seems such a first-rate service, but makes such a difference to vulnerable people and to make them really live an excellent life, that it's important that it's evaluated properly, and also that we outline how do we overcome some of these difficulties that face people and their children. So thank you so much for coming in today, and for that, and we look forward to hearing progress in the next 6 months.
We look forward to funding. Thank you.
Thank you.
Have a good day, everyone. Thank you.
Thank you.
Thank you.
Thank you. Lisa and the Llais report, which has been circulated.
Yes, thanks, Anne. So the report has been circulated, and I've also shared with you the quarterly impact report for information. So I'm just going to really just walk you through some key highlights, if that's okay, and happy to take questions. So just firstly, really, I wanted to show you, and this will be no surprise, but it is an area of concern in that we are noticing an increase around concerns in mental health services, and that's through our complaints advocacy service, but also our community outreach and engagement teams. In particular, that is around reduction of care, long waits for treatment and thresholds. And you will all be aware of the piece of work that HIW has recently done, also in connection with concerns around mental health and CAMS, which is being circulated. So I really did just want to flag that it continues to be a growing area of concern. And then if I just talk you through some other key highlights, we've had an influx really in our work with primary care teams, working quite closely with Lloyd around GPs and access, impacting patient experience, really is again a growing trend. And I know I've met with Liam, and this is an area that he is looking at and trying to put measures in place around the key concerns that have been raised. Also, I guess in terms of mental health, it's kind of bittersweet, really. We're hearing real key challenges for people on the ground, but I need to balance this out also. We are working closely with the mental health and learning disability team of Aneurin Bevan, and we are co-producing with a group of people with lived experience and our SLICE volunteers around creating the refresh vision statement. And I really believe there is genuine appetite to turn the curve, to really listen to our health population, to be able to work differently, to meet the growing pressures and meet patient experiences and improve them moving forward. So I wanted to share that really, because I think it's important to be balanced around some of the information that's within the report. Again, following from the last presentation, we had children and young people. This really is a key area, I think, for all partners, for us in Gwent and across Wales. SLICE as an organisation have elected myself as the corporate lead around children and young people, and we've now completed a full national stakeholder mapping exercise, and a mapping exercise for Gwent, which will be a pilot area to create a model to roll out across Wales around actively listening and actively responding to children and young people. Part of the work that we will be doing around that is feeding our child to adult report that will feed representation and feed areas of change that comes out of that piece of work early in the new year. Then just in terms of areas of focus, moving towards the end of this month, we're going live in Blaenau Gwent. It's the quietest area in terms of voice, so we are proactively going out with our SLICE locals to engage with organisations and members of the community in terms of their experiences with health and also social care. We're also doing a piece of work with Blaenau Gwent social care team around their recent reconfiguration of community mental health referral lounge duty desk. So again, I'd be really keen to share that with you, because that will move on to impact on beds and hospital discharge. So that would be quite an interesting piece of work to be able to share the findings with you. In terms of national work, I remember our last session together, I talked about some of the concerns and voices we were hearing with regards to dentistry, and you will be aware last week SLICE released their position statement and call for action across Wales around the current dentist crisis we have. And just lastly, I guess another key project, you would have all been part of the same day urgent care project, to which was operational across Wales by the SLICE team. For us in Gwent, that meant a 3-week period during the 30th September to the 27th of October, where we were live at the Grange, Neville Gwent areas, really trying to capture patient experience. We also held a series of online sessions and one-to-one sessions to create patient stories, really to enrich the experience, to make sure it's more than numbers. This is about people's lives. And that report will be produced by the end of the year to be able to share with yourselves and wider partners around really understanding the voice of people using our services. And then just lastly, I'm sure that I've been in contact with most of you around the table with regards to the new, quite exciting collaboration that SLICE are holding with the Bevan Commission around Silly Rules campaign, and this is around breaking the rules for better care. So we are currently live with this piece of work. If you do want to know more, please do drop me a note. It's very much making sure that we want to hear from staff and from the public to be able to feed into the Silly Rules campaign that will very much allow us to then collate the data, analyse the trends and share with you and look at a series of representations for change and conversations with Welsh Government moving forward. I guess that's kind of the key highlights that I wanted to share with you today, and happy to take any questions.
Thank you, Lisa. Are there any questions? Could I just raise one thing? In
Sure.
your report, In your report, you talk about sexual safety by patients accessing health services. Is this a specific Gwent issue, or is this part of the All Wales work? And have you any specific data on evidence that you might have gathered? Because I don't think we've received anything.
Yep, so this is an All Wales highlighted piece of work. Obviously for us is concerns about what does that mean locally. So I've been in contact with Jenny and raised the concern, and Jenny has informed us that Aneurin Bevan have created a task and finish group. They are responding. It's led by Aneurin Bevan's head of safeguarding, and they're looking at key areas around the sexual safety agenda. Also, reassurance was sought via Jenny in that this is also monitored via the All Wales National Safeguarding Team, which is hosted by Public Health Wales. So for us, it's about being responsive locally to a national issue that was brought to our attention.
Oh, that's really helpful clarification, because the way it reads is not quite like that.
Okay,
Paul, it's all right. Paul?
Lisa, thank you very much for the report, which is really, really helpful. Could I just ask you about, on the strategic plan, you've got number 1, drive a national conversation about the future of health and social care services. This could be really important for Gwent and probably the rest of Wales. Is there a time frame around that, so that the national conversation, when is it beginning, when is it ending, and when is it being fed into government? Because I think the message, we've got our message from a health board, but I think this coming from the voice of the patient may be quite a powerful evidence. So have you got a time frame for that?
So that was part of our launch when we rebranded from Community Health Councils into Llais. So that agenda and priority, with a series of 5 priorities, have been operational for the last 18 months and will take us forward until 2027. So they are our key main priorities. What we will do in 2025, a new financial year, is we would listen to the views on the ground and the experiences, and then we will launch under those priorities a set of refreshed priorities based on voice. So early doors, and we, in terms of conversations we've had, the priorities that will sit under those 5 are very much around mental health, neurodiverse, young people, and women's well-being in particular. They are very early kind of loud voices that we are hearing in order for us to press forward into the next financial year. But those 5 priorities, Paul, will remain the same in line with our strategic plan.
No, that's absolutely fine. I was thinking about the link between health and social care and the issues that there are within the communities over that, about discharge planning, etc.
Yeah.
And what the time frame is. Are you saying you're not going to report back until 2027, or are you saying that is there a progress review then at some point?
Yes, so there will be a progress review at the end of this financial year. So in terms of Gwent, under their priority, we are currently live with our hospital discharge survey, and we're having a series of conversations and focus group with key partners across health and social care, but also within our community. So we will be able to share their intelligence with you by the end of the financial year. But in terms of that overarching priority, it will continue, because there's no quick fix, and there needs to be pressure to make sure that we are all hearing and able to respond to what we're hearing to on the ground.
Yeah, that's fine. Thank you very much.
Does that make sense?
Yes, it does. Thank you, Anne.
Sure.
Thank you, Lisa.
Thank you.
Pippa and then Rob.
Thanks, Lisa. And I guess really it's just a little bit of a plea about the way that the report is presented to us, because we get things in here, statements like, we understand people are concerned, but I think for the board it's really helpful if we know how many people are concerned and what their concerns are, because I think it's only then that the board can make informed decisions. And knowing that people are concerned, we don't know whether it's 2 people or 200 people, or whether it's a range of concerns or one concern, isn't as helpful to us as it might be if there was just a little bit more granularity in the report. So I think there's just something around that kind of evidence moving forward that would just be really helpful if it was contained within this report. Thank you.
Thank you. Rob?
Yeah, thanks for the report. I want to pick up on the mental health point, and we're all aware of the increasing demand in mental health nationally, but more locally, some questions have been raised around the availability of some of the day centre facilities and day support through social services. So whilst we recognise the pressure in health and with our partners, will that be part of the review in terms of looking at the wider wraparound and integrated care for patients who require mental health support?
So if you'd like to forward places that you'd like us to have conversations, we can have those conversations. But at the moment, we're out to an open survey, which anyone can participate in, and we will be set up a series of focus groups, and that's face-to-face and online focus groups to hear people's voices. And in the new year, we will be going into a number of inpatients where appropriate wards to have those conversations. So if you feel there's an area that we need to be having a conversation to hear those voices, please do contact me and forward those details.
Okay, I'll probably suggest we do that through our division.
Okay,
Great.
fine. Thank you.
Thank you.
Are there any further questions to Lisa? No, well, thank you very much, Lisa, and thank you for your support and help.
Thanks, Anne.
Thank you. Right, 5.1 winter plan.
Thanks, thank you, Chair. This paper sort of leads on from both yours and the Chief Executive intro, really, and some of the key focus over the past few months. The paper has a number of parts. So first of all, it sets out the context for this winter in terms of what we can expect of demand and around infectious diseases, and then against the areas of health board actions, partnership actions and the prevention space. Sets out some of the actions either already in train or planned to come online that will help us manage the pressures associated from the increased demand and therefore our requirements for capacity flow, and importantly how we can manage safety. The paper also sets out the governance arrangements we put in place, and as touched on in your introduction, and that the RPB elements did come to the RPB last week. So just to draw out a few points on that, in terms of the modelling, using nationally produced and shared modelling information from Public Health Wales in terms of demand expectations around flu, RSV, respiratory, I can't remember what it stands for, but it's a respiratory condition, predominantly that causes paediatric demand, but not exclusively, RSV and COVID. So using that modelling combined with our own understanding of our patterns of demand, that work's been done, tested and iterated a few times. And I guess, and there's lots of detail in there, but the key message is demand will go up based on those that insight, with a peak expected in early January. And depending on, in terms of some of the variables, we could be looking at a bed equivalent, and that's an important word, gap of between 85 and 130 beds. So then the rest of the paper, the challenge is then how we mitigate that demand, and the answer isn't necessarily to put in 130 additional physical beds, but how we mitigate it through actions to mitigate the demand or bed equivalents in the community, and combining those actions together. So the rest of the paper then talks through, as I said, the health board actions, and I appreciate there's a lot of information in there, but just to call out some of the key ones from our perspective in the health board, in the context of emission avoidance, big focus on our frailty pathways through CRT, through what we call DAP beds, so direct admission beds, also through diverting patients into DVT clinics rather than coming to the front door. So a big stream around emission avoidance, a big focus on the processes and the way we work during this period, and then obviously take the learning into other into business as usual. So Leanne's been leading extensive work around what we call the operating framework, which sets out roles, responsibilities, the expectations of interaction, referral to, referral in, how we work really as a system, and that's being tested currently on each site with exec leadership. That's a key part of our plan to make sure we're operating effectively, that will support both safety and flow. in this space as well. We received at this last meeting a business case around the ED consultants and the discharge lounge. These are key important planks to our winter plan as well. Finally, just to draw out from a health board perspective, the capacity. I've touched on the discharge lounge, but also additional capacity. You can see going into district nursing CRTs. So this will be funded through the further faster monies. And particularly what we are working through the detail of the moment is the requirement for additional winter beds. So it's in the plan. Further work is ongoing to test opportunities in terms of where the model and the staffing for that capacity, with an intent to bring online to coincide with that surge in demand. The partnership actions are summarised. We had already some extant actions in the RPB or the system resilience plan, and then as we've heard already, that's been, I say complemented by, but subsumed really then into the 50-day challenge that we've touched on already in Jen's leadership on that on behalf of the RPB. So I'll maybe ask Jennifer to come in a moment when I've finished. And then finally, there's clearly an awful lot of focus around the sort of the prevention piece and the vaccination agenda. So our immunisations for those three infections I touched on that are driving demand. So in terms of where we are, there's a high-level summary in the paper. We are performing comparatively well in terms of coverage in Wales. However, we have a huge amount to do in terms of increasing our coverage. It doesn't call it out in the paper, but we started in October this year, whereas previous years, in terms of some of these campaigns, started in September. So like-for-like comparison isn't necessarily helpful in terms of time, in terms of month, because we started a month later. So that's a real part alongside our communication engagement activities. Resources, the paper's tried to call out where schemes have funding, whether that be through business cases approved, further faster money, the RPB system resilience plan. But really important to note, the RPB has at least 500,000 of slippage that it's agreed to allocate to winter, and it has agreed to delegate that to the integrated discharge board, which Jenny is the chair. So there are opportunities to fund unfunded elements of the plan through that mechanism. For the health board, it's important that we recognise that in terms of winter beds, that will be part of our approach into that unallocated. Underneath this, we do have a detailed a detailed sort of what I'd call in the programme and project management language a Gantt chart. So the actions, the timelines, who's doing what, so we can actually have something to measure against. And you'll see in the paper that will then feed into the governance arrangements that are set out. We've established a new winter delivery group to give that focus under Leanne's chairmanship, and the partnership items being held in the integrated discharge board, and a suite of metrics to track where we are against delivery. And then just finally, before I invite whether Leanne or Jen want to add anything, I just checked in this morning with colleagues. So in terms of, this modelling was done a while ago, well, a few weeks ago, updated in terms of we last received it in execs. We are tracking against the model at the moment, slightly down on, very slightly down on medical, but slightly up on surgical demand. It is just a model, but we are making sure we're tracking to see how we're actually faring against it, to see if we need to adjust plans accordingly. So I'll pause there. I appreciate there's a lot of information in the paper. Leanne or Jen, did you want to add anything? I think it's a pretty comprehensive update from my perspective, Hannah, so I'm just happy to answer any questions if the board has any. But
yes, similar, Anne. Just the one thing I would say about the 50-day challenge is we've done a lot of work to make sure it's not additionality, but actually what we've done is bring together and coalesce the projects we already have to meet the challenge, which I think has been important.
Yes, thank you. Thank you, Hannah. Are there any questions? Penny?
Yeah, I just wondered, are staff heavily involved in this winter plan, diverse group, because how for instance, what's the GP's reaction? There's obviously a lot of extra work involved, naturally. But what's the GP's reaction to this? Because, you know, they have to be on call much more.
Well, so I'm not sure they need to be on call. They're the way they are operating, but they are flexing in terms of, so the vaccination is a good example. We have, it's interesting, isn't it? Is that it was an area that our slice colleague Lisa called out, but we've got low uptake rates in Blaenau Gwent, so the NCNs in that area are going in and helping. How can we target to improve uptake in those areas? So there's a proactive engagement in terms of some of the key areas. Lloyd Hambridge, our divisional director for primary and community care, is heavily involved in the development of not just the 50-day plan, and really the issue in all this is where's the focus, where's the biggest, you know, there's a lot of stuff, but where do we really put our energy? But also that division are supporting the development of the other models, particularly around frailty and the direct access beds and the additional capacity we're scoping out in terms of are they that they'll be likely to be community beds rather than you know, acute medicine beds. So yeah, there's that's an example of how primary care colleagues are engaging, but others will see it because we've tried to, as I said, try to focus what's there already and amplify or scale up as appropriate. You know, obviously ED, we're building as well on the 6 Gold programme, I should have said. I'm building the actions train around enhanced monitoring, where there's great engagement across all parts of the system, really. So I think that's good.
Thank you.
Thank you. Rob?
Good.
Bill?
Thanks, Anne. Great report in many respects, I think. I mean, it hits lots of the bases, lots of good work going on. I particularly like some of the changes in structure, for example, the integrated discharge board. I think that would be essential. The delivery group, the delay group, I think will be, as long as it remains agile and in touch with what's going on hour by hour, basically, as we go through winter. I think that would be helpful. I'm not entirely impressed with some of the partnership stuff, if I'm totally honest with it. It gets a bit woolly. I see much more detail in what the health board are going to do. I see a lot less detail in what partners are going to do. And I guess that heightens my anxiety about where is the increased capacity generally in the community. Because it's okay to be trying to prevent admission, trying to get people out of hospital sooner, but unless those people are totally fit and don't need care services, then what do we do? So I think where it lacks for me, why it lacks confidence in a general improvement in the partnership footprint of what is out there. I mean, without sounding I don't want to sound negative with this because there's a huge amount of work in it, but it says to me there's an awful lot of effort in here from the health side. Without offending anybody or being disrespectful, I don't see the similar effort from the wider partnership body. At least that's not being conveyed to me from the report. And that's where I think the weakness is. If people may be out of hospital sooner, they may be planning going in, but a huge percentage of those people will need basic care. And I think care services are already stretched. I don't see where the extra is going to come from if we get a big push of people needing care.
So I'm sure others will come in on this as well. So you were at the RPB as well, weren't you? In terms
yeah, well, I said exactly the same the RPB.
Yeah, so. Like my view is some of that may be why the Care Action Committee was set up to try to bring together all partners in an accountability space collectively. Yeah. And through that mechanism then and the sort of the challenge around the 50-day sort of approach. I don't disagree, and I think we sort of saw that in some of the RPB. I guess I've never watched the show, but I guess so winter is still coming. So there's challenges we may have some challenges in that some of our levels of confidence, but I think that's all the more reason why we've gone sort of full on really in terms of our actions and control the things we can control and influence, and why I think it's a positive that the delegation through RPB has gone into that integrated discharge board.
So we can not just recognising, so we still need to work in the partnership space, but there's that level of influence in those areas. But I don't disagree. There's a challenge there, but I think that's something we have to work on all year round as well as in winter. But I don't know if other colleagues who are close to it ever do. I think that the additional meetings that Nicola's put in with chief execs of local authorities over and above the usual partnership mechanisms is helpful to try to get that collective leadership and ownership with I think an information feed going into there in terms of what's happening within the system, our modelling. Again, because I'm not sure there's been equivalent modelling in terms of what demand that doesn't hit hospitals from happen. So I think it's a fair challenge and risk within all of this.
Just to say, I don't disagree, Phil, around the balance. I do think we have seen a different response in partnership this year. It's not equal, but there is definitely improved working relationships with our local authority colleagues. We've been doing a piece around how we integrate Home First with some of our front door services into a single pathway. They've agreed to have a look at how we might create an integrated backdoor pathway, I'll call it. And certainly, they are working with us on and have committed to a review of trusted assessor. So I think whilst maybe the balance doesn't feel right, I think there is a willingness to work much more closely in a partnership way with us. And some of the actions within the 50-day plan, so there's additional social work capacity that's going in over the winter, for example. They're really focused on helping us with the admission avoidance and how we create a different offer in the community. So I have seen a very different approach. I think we are working very closely together in a way I haven't seen sort of in previous years. And I think there's a real opportunity with that, even if the balance isn't quite right yet. I've seen a slightly different approach.
Yeah, and can I say recognise that? I mean, you can see that. It's just the time perhaps that it takes.
It's timing,
the urgency maybe is different depends on where you sit and where you look. But I mean, I think there's some evidence, for example, getting the slippage through the discharge board instead of gas is a real coup. I know there's not universal support for that mine around the RPB table, but to actually secure that agreement, I think is a genuine step forward.
Yeah, because that'll give us the pace.
Yeah. Well, who's chairing that, Jen? Do you know?
Integrated discharge board, me.
Oh, good. Well, that's good. So that's another driver for you. Yeah, I would agree with Phil. It was an important step forward. A bit of a real focus. Yeah. Leanne?
Just very quickly, I think just to add to that, Phil, sort of, I always ask the question, so what? So what difference is that going to make? We're responsible for providing healthcare for the patients of Gwent. And we need to be clear that however we invest our time is getting a return on that investment, particularly because of, I think, the risks that we're carrying. So some of the focus on the operating framework and the transparency of the data and the evidence, I think, will help inform that. We're trying to get our own house in order in the first instance. But I've talked, and in the operating framework review that we did at Neville Hall, for example, last week, we had local authority colleagues there, and we talked about shared information and data. So actually we are using an evidence base. I think that's quite a big step forward, because I think when we've got the evidence, it would be hard for us not to continue to collaborate, because actually we'll do the right thing. And I know that there's a targeted piece of work around quantifying the impact of the 50-day plan as well, that's ongoing, that I think is at the moment not fully worked out, that I think should provide that assurance as well. So and a particular focus on the community capacity. I'm leading a desktop exercise around the community capacity, how we access it, how we're monitoring it, and I think that has great potential for us in the future, albeit I think sort of we need some response for this winter as well.
Thank you. Nick?
Yeah, I suppose just to add to all those comments, huge amounts of work going in. I suppose the reality is we're 6 weeks away from the peak. And, what difference are all those actions going to make on top of what we've got in our Gifted Health Board, trying to secure additional capacity, which isn't necessarily what we would choose to do, but, we need those levels of delayed discharge numbers to reduce by at least 50, you know, in the next 6 weeks. That's on top of us putting capacity in. You know, we're already full today, we rammed and we haven't got there. So that is an anxiety and the importance of this plan. And, you know, one of the things we've reflected is there's lots of this is what we're already doing and there's lots of it. So it's about which things will continue, but which of these do we need to lift up and put the resource and the pace in, as Leanne said, so that we can quantify or expect the so what to give us a level of confidence beyond what we currently got for the next 6 weeks. So that's where my kind of anxiety lies, is there's lots of great, and I feel that everybody is on the same page in terms of what we're trying to do, but there's a pace needed on some of those actions in the next few weeks that are critical to us getting through that winter period and the peaks that we might see in January. So, you know, and everyone is working really hard on that, but that's what we are particularly trying to focus on this week, is those big ticket issues that give us the greatest impact in the short term while we work through some of the longer term piece of the work. So I just kind of want to share there is a level of anxiety about understanding how quickly we can make some of this impact the people who are lying in our beds today that potentially don't need to be here, to give us the capacity we need to meet those who do need to come in.
Yeah.
And we're working hard on that, but you know, it will be a challenging few weeks, I think, to get some addition.
Yes, I would agree, and I think any help and assistance that the board can give, then we will, because this is a major problem and we're not far off winter or the real winter peaks.
Yeah.
And as you said, we are absolutely full to the gun already. And some of the regional partnership boards plans for last year, which have continued in part, didn't actually achieve what was necessary. So it's going to be really important that the St George board keeps an almost daily eye on have we reached the goal that we intended to for this week. And the board, I think, will need very, very regular updates on how we're doing so that we can take alternative decisions very swiftly, because we've got extra pressure in trying to manage the waiting list down as well. It's all at the wrong time of the year. So this is a very serious issue that's facing us, and I don't doubt the amount of effort and time and energy that's being put in to try and solve the problem, but I don't think we should be under any illusion that this is the absolute rock solid answer, because I don't think anybody's got the answer, and that we will do our very utmost to support the propositions that are necessary to help us safely get patients through the winter and out the other side, giving them effective care, and to support the staff to ensure that they can do that. So I think Nick and I need to have a discussion about how effectively, without causing even more stress and hardship in terms of monitoring, the board can really be kept at pace with what is going on and the epidemiology that's coming through, and whether it's being realised. So is that okay?
Yeah.
So we note the winter, yeah?
Sorry, I'm just so that it might help. We agreed, Jen and I, sort of following a meeting yesterday, around producing sort of what's going on in winter, a weekly update. So possibly
good.
sort of we could
That'd be very
use
helpful.
that, I think, sort of in terms of both the modelling and I guess key actions and progression around certain things. So we were going to do it for staff because I think it's really important.
It is.
I know our staff are really concerned coming into sort of the winter period as well. So we thought it was a good way, I think, just to keep people appraised.
That's helpful. Yes,
And
Jen.
then we're working on a dashboard for the 50-day challenge, so we should have that feed of data to enable us to be able to make sure that we're making that difference. So with both things, I think.
Can that be shared with IMs? Was that your point? That would be shared?
Yeah.
Okay.
Yeah.
Just checking that was your point.
Yes.
Sorry.
Yeah. Okay, so obviously we know the context of this. The actions that are promoted in it are fine and endorsed, but we all know we need to go further. And that is part of the updating for this board, in case there are additional, very short notice actions that need to be taken, because we have to keep people really safe during the winter and beyond. Okay, thank you. 5.2, are you all right? 5.2 improving waiting times for planned care and diagnostics, all to be done at the same time. Leanne?
They're trying to tip me grey, I think.
I think they are. I think
And they're
right
succeeding heavily. So I guess, it is very much a good news story. I think on to one of the other key ministerial priorities, planned care. The board will be aware that in order to try and balance our financial sort of responsibilities alongside the ministerial priorities, earlier in the year we focused largely on sort of cancer and 156 weeks of delivery. As a result of further conversations that we had, we placed some limited investment on trying to improve the 104-week position in May of this year. We had, and Anne's already alluded to the fact there's a heavy focus from a Cabinet Secretary perspective, performance management approach, and rightly so for people waiting a long time for their elective care. 3 key specialties just to draw out: ophthalmology, ENT and orthopaedics. And even with our limited investment, the trajectories that we resubmitted in May showed an improvement of in excess of 4,000 people. From March 24, the annual plan submission said we would have just over 8,000 patients waiting over 104 weeks. And in the revised trajectories in May 24, that reduced to just under 4,000. In addition to that, there was a target set around diagnostics. Waiting less than 8 weeks had to be at 95%. 3 key areas for us are under diagnostics: radiology, endoscopy and neurophysiology are the main sort of drivers there. In August, we were asked to resubmit costed options into Welsh Government around the art of the possible, and we undertook quite a lot of work. We'd already been working on that anyway from an organisational perspective. We did a significant amount of modelling and work with the divisions to work up some plans. And in mid-October, we received confirmation that we received just over, and as I said, Nicola's alluded to this, just over £5 million, £3.8 million to address orthopaedics, and then £1.3 million on diagnostics, mainly endoscopy, but neurophysiology as well. That will treat 3,728 patients in orthopaedics. So again, it is a very good news story for us. And I think important to note as well, just some nuances to the submission that we made. It includes a reduction to 26 weeks for routine paediatric patients in orthopaedics as well, and a reduction to 8 weeks for urgent paediatric patients too, noting our ambition around best start in life. We also submitted plans around ENT and general surgery, high volume, low complexity lists as well, alongside some non-cataract ophthalmology submissions too. We haven't received any further information in relation to those bids that we submitted, but again, I think important to note for the board, we have gone at risk at just under £100,000 for 1,000 ENT outpatients. Welsh Government are aware of that. I know Nicola, we've talked about it in terms of the Innovation Reserve, but I know Nicola has also written back to Welsh Government noting that the teams are ready to deliver on that activity, and we would be keen to deliver on both ENT and general surgery as well. I guess a couple of things to flag from a board perspective. The funding is non-recurrent. The release of monies at this time of the year presents quite considerable operational challenge, both from a procurement and a delivery perspective. And I think particularly set in the context of RTT and the skills and capacity and people with the experience of delivering this, sort of particularly post-COVID. So I think the risks are set out in the paper as well. The teams are working incredibly hard to ensure we're delivering on the ambition of getting as many patients seen as possible, noting that there's a patient at the end of these pathways really. But I think just for the board to know the submission, the funding received, and the plans that the divisions have submitted in terms of delivery of planned care ministerial priorities.
Thank you, Leanne. Are there any questions?
Obviously, very encouraging to see that you have made good progress and obviously getting the extra funding. And I suppose it's highlighting the sustainability, isn't it, as to how people keep on delivering, isn't it?
We've begged almost, I think fair to say, certainly at the COOS, a regular meeting with Welsh Government on a number of different ministerial priorities. And our plea has always been to make this recurrent funding, so we can deliver this on a more sustainable footing. We can recruit staff. It does rely on staff stepping forward and undertaking the work, and it's already incredibly busy, as you will have heard. I think there is hope that it will be recurrent for future years. We haven't received notification of that, but as I said, I think we are hopeful that that will be the case. And the divisions and the directorates as well have developed sustainability plans that should that money become recurrent, then we should be able to proceed with our plans on that, dependent on the demand capacity modelling. We will have a better handle on that. We've done a first round of demand capacity modelling for next year and readiness for the annual plan. So teams are ready to rock and roll should that funding, as I said, be identified. And as I said, sort of, I think we're just keen to achieve that ambition for lots of different reasons. The impact it has on primary care, not least the impact it has on patients that are waiting long periods of time, and also emergency admissions. You know, some of the lap chole patients, for example, in general surgery recurrently attend as emergencies whilst they're waiting for their procedure, as well as it being incredibly unpleasant for them. So I think our ambition would be that would be recurrent funding.
But also the workforce can't keep working that level of commitment and extra sessions and weekends, and isn't it? So it's getting it back to what is a normal, sustainable. Thank you.
Absolutely.
I have a couple of questions. What is the degree of risk for delivery? And I'm sure you've done this. What are the consequences of the conversions for next year, and how are we measuring quality? Because we need to keep that at the forefront. And are our solutions, I know jolly well that they've been really hard to secure the solutions, but are they really value for money?
I think I'll take them in probably in reverse order. So I think the value for money is really difficult to deliver when the money is given to us as late as it is. So to a certain extent, it really ties our hands around the solutions we've got. Clearly, from our perspective, we try, because we know that there's additional patients that could be treated if we are able to deliver, I guess, a more value for money sort of scheme. All of the schemes have been through feasibility tests. We will not, as you know, as a board, we will only commit to trajectories that we are confident we can deliver on.
Yeah, we need to keep to that.
Absolutely. Can I categorically 100% say that we'll deliver on that? Well, 2 CT scanners going down last week suggest that operational life happens. And I would be misleading you if I said I can guarantee that, because I can't. And the circumstance of our reliance on the workforce to pick up the additional sessions. You know, orthopaedics, as an example, have historically delivered 40% of their activity through additional activity. And if there's no will from the orthopaedic teams to do that, then there's a limited amount we can do. We are looking at alternatives, for example, outsourcing and insourcing in other specialties to inform that. So in ENT, the solution is insourcing because we don't have an internal solution. So the schemes that we've put forward have been tested in terms of confidence levels that I'm certainly happy we commit to, and I know we've had a conversation at execs on that really. From a quality perspective, I think we always look at the quality. I think the long wait is a safety issue for us anyway. So actually in taking the weights down, that I think in part helps us, I think, with some of the quality issues, those recurring emergency admissions, for example, for the lap chole patients I keep referring to ongoing medication for patients with osteoarthritis, those sorts of things that we don't always track. We do need to revisit where we're at, I think, in terms of proms and prems around elective activity more than we have done. But I think that's certainly something that we can build in sort of and just make sure we've got much more transparency on that for next year's annual plan.
Yeah, I think that'd be helpful.
Do you mind if I ask a question?
Yes, certainly.
In the meetings you go to with the COOs sort of nationally, I mean, is there a discussion of kind of baseline capacity demand? Because my understanding from the conversations you led amongst us is that ENT has a big backlog, that once they're back at stable state, there's more of a match between capacity and demand. But as you just illustrated, orthopaedics at steady state is so far from being able to meet demand. But, you know, a new consultant surgeon costs about £1 million each. Once you look at all the on costs and the work they generate, and I haven't heard the details about ophthalmology, but my understanding is that's a similar position. Is there any acknowledgement of that at Welsh Government level, that actually we're at the wrong baseline, we don't have the money to invest in the services we need to stop this happening again?
Well, as you'll be aware, we've done a number of deep dives into, in particular, those 3 specialties, and papers are in the process of just being finalised to share with Welsh Government, so they've got a very clear line of sight of recurrent imbalance in terms of demand and capacity, and what's backlog, so that they can see what that looks like. As I said, we've just done a first cut of DEM cap in readiness for next year, so I think we'll be able to update it in readiness for annual plan. I am truly hopeful that there will be recurrent monies available. I think that will help our planning and then delivery into next year.
Yeah.
But we will need a range of an increase in capacity alongside some transformation, and that is the part we heard in, for example, surgery's mid-year review yesterday, of an agreement that the surgeons have got a standardised agreement around HVLC lists, high volume, low complexity lists. Each of the surgeons will do one a month. So I think those sorts of expectations from GIRFT and the transformation, as well as sort of maximising efficiency, I think will play into a range of different measures we'll need to reduce long waiters further.
I mean, that was a fantastic bit of work from the surgeons that we heard about yesterday. The high volume lists, they're operating on double the number of patients by selecting out the lowest risk patients. It's really impressive.
Good. I think it would be helpful for the board, the whole of the board, to see the paper. Sure. But Rob?
Yeah, just pick up at a couple of things, and Leanne mentioned the word feasibility in terms of the round now with the funding and the non-recurrent nature of it, and the very hard push to get activity through. The feasibility has been the biggest driver. Lots of work internally, and as Leanne's mentioned, having to go beyond internal solutions through insourcing and outsourcing. Value for money isn't a big driver for that, because we wouldn't be able to put in sustainable solutions, and the recurrent sustainable solutions with recurrent funding is the best value for money approach we can take. Helps us to improve our efficiency costs, mind, in terms of doing more activity, so there's that marginal rate as well. The other thing to note, because it is sort of external to us, but we're involved in it, obviously, is regionalised. So Nicola mentioned earlier, we've had an extra £7.5 million. So that's going out through a contract that we are letting as a health board on behalf of the 3 health boards in the region. That should get through 5,000 cataracts. The providers have undertaken to deliver this, but again, it's pressure and feasibility in the operational processes to get there. And then the last point on outcomes, and again, Leanne mentioned a bit of proms. When we had the value-based healthcare update, hopefully people remember that we're going to go to a new proms platform in the new financial year, which will give us a much wider number of available slots to capture proms. But again, operational pressure to make it go live. So we'll have the system, it'll replace what we've got now, but there is a lot more to go further on that.
Thank you, Rob. Any further questions? Obviously, we will be held to account thoroughly in terms of the delivery of this. So I think it's important that the health board is kept updated very, very regularly. And of course, the performance subcommittee will be taking a very considerable interest in this and scrutinising on our behalf in the interim periods. Okay. Could we go then to refit?
Thanks, Anne.
Thank you.
So this paper outlines the Aneurin Bevan proposal for using the Welsh Government refit entitled framework to secure investor save funding to deliver decarbonisation and renewable energy schemes. Back in 2021, an initial case was put to the board and approved for a refit proposal to be developed, and this is the follow on from that exercise. So the health board has worked with local partnerships, in inverted commas, and that's a government sponsored body, and the Welsh Government Energy Service to help us develop the progress to a refit bid. We've done that through a tender process, and a consultancy firm called Vital Energy has been selected to work with AV to develop a high-level assessment plan, which has been undertaken, and then to turn this into an investment grade proposal, or an IGP, which is referred to in the paper. That investment grade proposal then will be part of an application for funding to Welsh Government through their department called SAILEX, and then ultimately that will be the business case that goes forward. There's a few groups or titles or functions in here. The simple message is we are working with a consultancy firm to submit a bid to Welsh Government to achieve Welsh Government investor save funding. The reason I say that in that simple way, because it does get lost a bit in the detail. In terms of the proposal, an expression of interest went into Welsh Government via the SAILEX team for a 2-year investment request. Several schemes, including LED and solar, were submitted. They're in the paper in the schedules. The investor save minimum target criteria for Aneurin Bevan's proposals, we require a £7 million investment for a 10-year payback period, a return of £350 per tonnes of carbon avoided. Our current HLA or high level assessment doesn't quite meet those requirements, but the work now between now and the investment grade proposal will be to refine, revisit and basically achieve those minimum standards. And we have confidence in that because we're quite close. In terms of savings of the order of £730,000 per year, obviously that will fit with the revised costing and the detail done, break even and repay the investor save over the 10-year period. That saving reduces our carbon impact by 995 tonnes per annum in terms of emissions, which is 6.6% reduction overall on our AB footprint. There are some additional capital expenditure requirements of about £300,000 that would be put through. The intention is to put through our discretionary programme, so that would be something for our plan for next year and the year after to support this whole programme. And Vital Energy, as part of the framework, the refit framework, will guarantee our savings returns. So there's minimal risk and good impact in terms of our carbon footprint for the future. So that's the overall proposition that's been put today. The board is asked to do 2 things. One is to discuss the paper and consider it. The second one is to approve the delegation of the decision and consideration of the investment grade proposal, to delegate that sign off to the exec committee, simply because of board timings and the need to get a submission in January to meet the refit timelines of submission for consideration of funding.
Thank you, Rob. Are there any questions, Pippa?
Yeah, I think that, I mean, anything that we can do that responds to climate change is a good thing in the broader sense. But what I didn't see in here was the kind of if we had any redevelopment projects in mind, for example, or any older buildings or those kinds of things that, I mean, we've got the rack in Neville Hall, for example, and that's a classic example. Would we be investing in LED lighting, solar panels, all of those kinds of things, just for those buildings that we know we're not going to be making any changes to? Or would we be investing in buildings that we subsequently might make a different decision on how they're being used? And I just didn't see it in the paper. And so I wondered, you know, if it was possible to give us a bit more detail on that.
Yes, there's been an extensive review. We did have an initial survey of all our sites, but things like the rack emerging have reduced the profile of the plans around Neville Hall. When we build new buildings, the decarbon impact is factored into all, and renewables is factored into all of those, and consideration has been given to the longevity of the plans in terms of where we're going to implement some of these.
Thank you. Ewan and then Neil.
Yeah, probably adds on to what was just brought up. My concern will be, how does this fit into our premises plan in general? Because we're talking a 10-year payback period on this project. Where are we in 10 years' time? You know, what does our estate look like in 10 years' time? And then it feeds into the, if we're not going to be in a particular building in 2 years' time, why are we bothering doing this now? Or is there more that we should put into another building that we are going to have in 10 years' time? And it's that missing link between this and the estate plan that worries me a little bit.
Rob?
So just sort of repeating what I mentioned, the consideration of where we are and what we know now has been given. But picking up Ewan's point, yeah, you know, if our estates plan changes, then it might have an impact on this, but this is based on decisions of where we are now.
So yes,
I think we need to be a bit cautious, aren't we?
Yeah, so I guess the follow-on question is, when will we get that estates plan that kind of ties all this together?
Anna?
Yeah, I just think, I don't know, Jamie's on the line as well, who's very plugged into all of our estates programmes, understandably naturally. So in the paper, those areas where there is focus in this paper, so I know St Willis is there, but the plan is to keep an element of that. We'd be agile, to pick up on Rob's point, is we wouldn't be doing this work in areas. So those sites, I guess is what I'm saying, when we've got the Grange, Sereni, Neville Hall, Chepstow, are features. We've features of our future going forward in terms of the services that are on there. The Neville Hall, the specifics of the Neville Hall will just have to be agile to where we are in terms of the Neville Hall, the SOC and the emerging and developing business case session on that in the next board development. But I think through the linkages through Jamie's team directly with this, and Jamie directly heavily involved in the St Willis and Neville Hall and all our estates projects, I guess the risk is we do abortive work over here and then 2 years later it's decommissioned. And yeah, so I think that risk is managed that way. The specifics on the estates plans, we've talked about it in board development, will come in to a place with the organisational strategy. And it's important that estate strategy and plan follows on from that. But there are some, as we've picked up on the estates, the extant estate strategy, some key key features that will exist. The Grange, for example, Royal Gwent, Neville Hall, we've committed to the future of, what Neville Hall that has a future in terms of our sort of suite of offering. We've just bought the lease for PFIs so some of the areas that are called out in this plan, I think, do align to the extant plan and where the plan will end up being once we finalise the organisational strategy and updated the estate strategy in line with that. So I think they can be. I think it's, as Rob said, I think it can be managed through the interconnection of the teams and the areas that it's focusing on in the first instance.
So just to confirm that, when is that estate strategy going to reach the board? It's not a question I haven't asked before. Obviously, I'm still looking for that estates plan. I guess.
Yeah. So I think we've been I think we'll have to come back to that when we talk about the Neville Hall plan in the board session, because we have agreed, as my understanding as a board, that we'd let the organisational strategy play out and us finalise that first, so that we can hang the estates and a number of other strategies off that. To the last planning committee, we gave quite a detailed update on where we were with some of the key estates objectives, which still remain extant. I think the real gap for us in the estates strategy is in the community space, be that the mental health community provision, which the teams are doing a lot of work on the vision and strategy, and in our community services. So that's not, I'll have to come back to you on an exact date for when we align on the other strategy work we need to do.
So does that mean for the next board we can have a timeline on this? Or?
I think we'd pick it up in the next planning committee.
Yes, the next planning committee.
Next planning committee.
Neil?
Yes, thank you, Chair. I'd just like to mention again this point about the application of AI, Rob, to our goal here in terms of reduced carbon emissions and energy saving. I would see that as being supplementary to considerable capital investment here. But although I'm no specialist, I do believe strongly that for considerably smaller capital investments, there are considerably greater energy savings that can be made through the application of this technology. That's the sort of figures I've talked about. I understand are around about 30%, which is significant.
Nick? Yeah, I just want to, I suppose, pick up and follow Ewan's point, which I know we've had various conversations about. So I suppose just manage expectations. I think the work we're doing on the Neville Hall timeline in that paper would probably be a good opportunity to put alongside the timeline of refreshing the broader strategy, because we will also have hopefully finished the work on the broader strategy. And I say that in the context of our previous conversations about what we've got to do in the next few months around the winter plan, the plan care. I don't want to promise something that we can't deliver. And I think we've even had a discussion about, we're trying to pull together the overarching strategy over the next few months, which again is challenging. So I think we stick into that commitment. I think by the time we get to March, if we've got a new overarching strategy, we'll have Neville Hall work starting to come together. It's a good point to then put the timeline of how we then develop that broader estate strategy, that we can give you a little bit of that line of sight of when we get to produce a refresh, recognising we've got an estate strategy in place at the minute. There's quite a lot of work going on within that. And I think just to reinforce the areas that's in this paper, I don't think are a risk because of the areas which feature in our future plans, really. Recognising there'll be some nuances to that. But I think just in terms of the timeline, bringing in the timeline alongside Neville Hall would probably fit well with the strategy work and give us that time to map it out and the mental health work that's going on. So I think we can answer your question in terms of, when can I expect this, that we can then start delivering to.
Nice.
But I don't want to promise something in January that with everything going on is probably not going to give the time and, diligence to what we need to.
Are there any further questions? Are we content to approve this so far? Bearing in mind we don't want to invest in anything that's not going to be there within the timeline. And are you happy to approve that the executive committee have delegated authority to invest as proposed? Yep.
Thank you.
Thank you. Oh, bye.
Thanks, Jamie.
Thank you, Jamie. 5.4 Quality Improvement Strategy, Jen.
Okay, thank you, Anne. If I may, I'm just going to set the context of why the strategy is important. And I know we had a board session in October. Quality improvement is an approach where the focus is really on identifying unwarranted variation and harm and putting into place strategies, projects, processes to root out that harm. Now, we know the NHS, the costs of harm are significant. And I'll just quote you some figures just to set the context. So if you just take medication errors, there are 237 million errors that occur annually in the UK. They cost the NHS 98 million and 181,000 bed days, contributing to between 712 and 1,700 deaths per year. The World Health Organization have looked at errors in medication. They estimate that it costs 42 billion globally. For falls, the annual cost to the NHS is 2.3 billion, with a loss of over 4 million bed days. And a fall will double the length of stay, and they estimate that that's around 70,000 hip fractures. The Organisation for Economic Cooperation and Development estimate that the direct cost of treating patients who've been harmed during their care approaches 13% of health spend, and that excludes safety lapses that may not be preventable. In addition, we have hospital-acquired pressure ulcers. They cost for each episode, they cost between £1,200 and £14,000 of extra cost to the NHS. And that's estimated between 1.4 and 2.4 billion per year. If you just take one example in one of our own divisions, 4 avoidable pressure ulcers in a month, as you can see, that will cost anything between £4,000 and nearly £60,000. So whilst the strategy is absolutely about improvement and a focus on ensuring that there is a high quality of care and a patient experience, there is a compelling issue here in terms of how we root out that unwarranted variation and harm within our beds every day. You'll see from our quality report that harm does occur in our health board every day. So from my perspective, the quality improvement strategy is not just a strategy about how we do QI in this organisation. It's a strategy about how do we provide safer, more cost-effective, high-quality care that delivers a better patient experience. We also know from the international evidence that quality improvement has a huge impact on staff morale and welfare. Where organisations have quality improvement systems, there is reduced sickness and there's also reduced improved well-being, reduced sickness and reduced turnover. We also know that it helps root out waste in the system as well, because if you look at some of the QI opportunities through the sustainability agenda, we know that QI and that focused attention to QI can obviously root out unwanted variation in use of consumables, time spent in clinics, and improve processes in a way that ensures that there is a more cost-effective response. There's also the patient satisfaction and patient value within that, and the improved patient outcomes, which again are well evidenced on an international stage. So the QI strategy is about an approach in Aneurin Bevan. It's about a way in which, over a period of time, we will create the right conditions for our staff to be able to own QI, to be able to identify harm and variation, and to not wait for permission to address that. There is nothing more frustrating for clinicians when they know that harm is occurring, they could do something about it, and the systems and processes around them stop that happening. So this is about ensuring we've got the right approach with our staff to create the right conditions. There is an element of training in here, and this is about the CPD rather than the other training that our staff have to do. This is about creating a CPD opportunity for doctors, nurses, therapists, health scientists that equips them to do something that will bring something back, not just to the organisation, but to them and their patients. So this is an approach, it's a long-term approach. It will take us over a 5-year period, at least, if not 10 years. And some of the best organisations in the world, if you look at East London Foundation Trust, their approach has been running for 10 years. I have a friend in England who has a QI faculty. It's taken them 15 years to embed this truly. But you have to start somewhere, and you have to start from a premise of what can we do that will make a difference to our patients and our staff every day, but will deliver up a financial cost effectiveness and efficiency benefit as well. And QI will do that. QI has had a bad time during COVID, I think that no doubt across the whole of the UK. So this is an opportunity for us to reset, refresh and to move forward. We'll link it in very heavily to our annual planning processes. We'll make sure that it's linked into our ward accreditation processes. And as you know, when I've talked about ward accreditation previously, QI is a core element of that. So no ward will be accredited without a QI project. And that will be about them being able to be free to identify where harm is occurring and putting into place mechanisms and projects to enable them to reduce that harm. There'll be then an opportunity through our new learning and improvement group to share that learning so we can spread across the health board where we're aware of those opportunities. So for me, this is fundamental and core to what a clinician does. I think it's fundamental and core to their CPD and their development. And we've got to invest in their professional development as well as their general development needs. So for me, this is a organisational approach that really needs to take us forward into the future. And we will be able to track the benefits. You'll have seen some of the examples of the projects that were talked about in the board session, where there's been demonstrable change as a result of the intervention. So an estimate of £250,000 saved on Never events because of the work they've done in theatre, which focuses on a human factors QI approach. So I'd commend the approach to you. I think there is further work to do, and we will, with Anne's permission, obviously want to bring back updates on, what are the benefits from a staff, a patient, and a cost effectiveness perspective. But this gives us a platform to do that. But it also unlocks what we know, which is that clinicians want to do a really good job every day, and it unlocks their ability to do that.
Thank you, Jen. Any comments or queries? Penny?
I don't know where to start. Seems to be some repetition. For instance, in September, we had a presentation about the quality strategy programme plan, and that involved obviously, patient-centred, safety, etc., efficiency, and all the other things that we're mentioning now, whole systems approach, for instance. And I just wondered, it seems to be overlap. Is it going to be replaced? Is it going to be brought together? How does it work? I'm a bit confused about, we're getting kind of the same commendable points made, but from different regions. So the central bit seems to be the same.
So our quality strategy is our approach to deliver the health and care standards, and obviously the new duty of quality. Quality improvement is a key element of that. If you read the strategy, it will talk about quality improvement in parts. What we're doing is saying, we know that quality improvement is a key building block of our overarching quality strategy. And by setting it out in this way, what we're doing is saying, this is our approach to that. So whilst the quality strategy will identify how we identify some of those issues and harm and that learning, the QI strategy and approach is really about how we do some of that. And really the opportunity lies with our staff who are, I've got staff itching to do QI projects. If you look at our hospital acquired pressure ulcers, actually we have an improvement club that's run for 2 years now. It runs under the radar. When divisions notice variations, they immediately go back to the actions in the improvement club and then reduce those. If you look at the data from surgery for this year, they've reduced from 4 to 0 with their avoidable pressure ulcers, which are the ones we look at. So really this is about our delivery mechanism to achieve some of that, because we can identify the harm, but if we don't put in those improvement opportunities, we're obviously failing our staff, but also we're not able to pull back that harm into, rooting it out and reducing that variation.
And how much, can I ask another, Chair, and how much extra training will this mean for the staff? And have we got the capacity to for that training to be successful, be carried out?
Absolutely, Penny. So it is a day or two of training. It depends on which course they follow. So there are various levels. You have improvement advisors, coaches. So there's various levels, and this is about giving them the skills to do their job well. And I think it shouldn't be seen as a and/or. It's a must do, because to keep my registration, I have to be able to demonstrate that I'm continuously improving my practice and my care for patients. This is a mechanism to do that. I think there is something about how we enable QI capability and capacity in non-registered groups, but for me, for the registered professions, it's a must do.
But have we got the capacity to enable that to happen?
Yeah.
Rita?
Just to add to that, I think maybe in the past we struggled with that capacity to support and train our workforce to do this. The model and the approach described here is a more realistic way of delivering that through developing QI coaches, who are people on the ground who can take the skills back to their teams. It's almost a train the trainer type approach, which for me feels probably the most sustainable way forward, rather than having a team of experts remote from the shop floor who tell you what to do. And I feel this is a really positive shift and change. Completely agree with Jenny. I think this is really CPD for our staff, and if we don't support our staff to do ongoing CPD, then we are really neglecting the workforce. And the other bit for me is because, we've got loads of demands on us and juggling priorities and trying to work out what do we do and what do we not do. This is expected in the duty of quality, and I think very often it's a legislation that guides us in what we need to do as a health board, what we must do. The duty of quality makes it really clear that we must take an approach around continuous improvement. So if we come back to the legislation, it's really clear this is expected of us as a health board.
Thank you, Peter. Are there any further comments? Neil?
Thank you, Chair. I'd just like to endorse really QI as a approach to achieving organisational goals, staff satisfaction levels, and even financial outcomes. And so I completely support this approach. My concern really does mirror Penny's around the staff capacity, particularly at this moment in time. And all I would say about that is I think that, and Peter touched on it, I think, that if we view this as part of CPD, is there not an opportunity for us to have our cake and eat it by saying, okay, QI is really important to us, we've got to develop this, push it forward. And maybe there are some things that we can say, actually, if we're going down a QI route, these things perhaps are less important and we can do less of them, and thereby not massively restrict or add to staff burdens as they stand.
That's the whole point in QI. There is a opportunity around clinical and cost effectiveness. So can I give you one example? So when I arrived in the health board, the health visitors literally had records that were like that. Literally, honestly, I gave Nick a copy. Huge. They've done a QI project around reducing the content of the records without reducing the quality or the impact on the service users and their families. They've now got something that's about that thick and has reduced their time in record keeping by hours. So the productivity we've got back and families have got back from those health visitors undertaking a simple QI piece of work as a team to say this is ridiculous, we are repeating records over and over, has actually released their time, but they needed to be able to sit down, take 5 minutes and think, well, actually, I've got an opportunity to release this. And it just, myself and Nicola giving them the permission to do that, you know, it's released hours. If you talk to them now, they would talk so positively about the impact.
Ownership is key.
Yeah, the ownership is absolutely key. And I think we can have our cake and eat it. I know I'm a big advocate of QI, but if you look at the high performing organisations, QI is embedded.
Paul?
Can I just say I applaud this initiative and I applaud the approach, Jenny. I think it's a great initiative. My only issue is following up really from what Penny has said and what Neil has said is about workload and capacity of staff. So my first question would be, how have staff been engaged in this across? We've got 14,000 staff, and how have they been engaged as part of their, perhaps the trade unions or the professional associations and their sort of view on this? That's the first question. And the second question would be, I think there's an opportunity for this to be a catalyst to review the mandatory and the statutory training element to get that fit for purpose, because I think the QI is the way forward. And the reason I say that is because it's about problem solving at the workplace. And actually, I think that's far more important than sometimes some of this ESR training, which people have got to do, when in fact, if they were given the time to think, okay, some problem solving time, I think it's far more effective, efficient and more fit for purpose. So those two areas really, Jenny, I'd welcome your observations on.
So we've not specifically engaged the unions, but I can certainly tell you the professional unions would be absolutely in support of this approach. You know, I think there is a huge amount of support for QI as a methodology. And actually, through the ward accreditation pool, we've already engaged with, I think we're up to about 10 wards. So staff are absolutely engaged with this. You'll have seen in the board session we ran, there are a number of staff engaged in quality improvement projects. We had the Safe Care Collaborative previously. So, you know, we've got that multi-professional viewpoint on the opportunity this gives us, but also through our ward accreditation, team accreditation, this becomes just the thing we do. So it's not additionality, it's just the thing we do. And actually, if you think about the time it takes to dress a pressure sore, the time it takes to, you know, assess someone after they've fallen, the time it takes to investigate a serious incident. This approach is about stopping all of that and trying to get into situations. There will always be serious incidents, but it's trying to identify the early triggers so we can prevent those catastrophic things happening. And that's where you start to get the benefit from a rounded approach, as I say, from the money, the performance, the staff well-being and the patient.
Okay. Leanne?
Just to endorse the strategy, I don't think we can afford not to do it, because we'll just keep doing what we've historically done. I think my and the team's frustrations in terms of the wider sort of staff engagement piece is that we've trained hundreds of people in different quality improvement methodologies over the years, and we've not corralled them or pointed them in one direction or used one particular methodology and then embedded that in the organisation. And I think that then is a false economy, and we've not really capitalised on it. So I think there's a real opportunity for us to get our backs behind this, deliver it in a consistent way that I think would significantly improve morale alongside the quality benefits that it brings, really. And it is a very worthwhile, I think, investor save. So I think just to support the consistent approach and then sort of holding firm on that approach. I think from an organisational perspective, we've got hundreds of trained people out there in the organisation at the moment.
700,
I think. Yeah, absolutely. That we've trained in different skills that we're not capitalising on, that I think would make it a huge difference for our patients and the teams that they work in. So just to support.
Start off by saying I am absolutely committed to quality improvement. I think is absolutely key to everything you do in any type of organisation, alone health organisation, manufacturing, service industries, everything. You have to look at quality improvement. I carry the scars of many a different version going in, from Six Sigma to Lean and all the rest of it. And obviously, we've been trying to do this for 10 years or 11 years or whatever it's been in this organisation. The risk of any of this is that it just becomes a training exercise, that you train people up in different methodologies, and the cost of that is tremendous. Now, one thing I would like to see in here is what the cost is going to be, because there are no figures in here at the moment around the cost of it. And what you end up with is, as we've got here, a plan at the end that tells you how much training you've done, how many accreditations you've got, how many people are actually doing this, how many trainers and all the rest of it, and not what it actually gives you as a benefit. There is nothing in here that says, oh, we will have improved this many systems, this many patients' experience. There is none of that. This is all around training. You've got here a lot of professionals, you've got a training trainer, and it just becomes a factory of training people who can do this and not actually implementing the stuff that we've trained them to do. And that's always the risk of this stuff. So many times I've seen Six Sigma come in, people trained up to green belt, black belt, and as soon as they're trained, they'll leave, go somewhere else and be a trainer somewhere else rather than bring back the benefits of this. So what I would really like to see in this is what the mechanism is going to be for the cost coming out of it, and actually tracking the benefits that are coming out of it, etc., and being able to show that the benefits come from this process. Secondly, the other bit, in audit committee, the number of audit reports that we see that criticise our levels of training in terms of the mandatory training that we're supposed to be doing, the risk here is that we'll do even less of the mandatory stuff and we'll do this. If something goes wrong in this organisation, we will not be criticised because somebody didn't do their quality improvement training. We will be if they haven't done whatever the other mandatory training is. And I know it'd be slightly different if it's CPD versus training, but if we're not doing our mandatory training, surely we should be focusing on that before this. So, I mean, I would say that if you haven't done your mandatory training, then don't do this, do your mandatory first, then this.
So, I guess my response would be, Ewan, is that you will also be severely criticised if clinicians don't have time for continuous professional development. In fact, the greatest number of severe incidents I see are not about delivery of mandatory training, it's about delivery of continuous quality improvement and CPD. So, from a clinical professional basis, and James and Peter may want to comment from my perspective, mandatory training is one thing and very important. That isn't the only thing you need to do as a clinician. You need to be able to demonstrate your clinical skills are continuously developing. I think you missed the board session, Ewan, I think, where we did, were you in the board session where we did the development in October? Yeah. So you'll have seen some of the projects where we've started to bring through some of the benefits, and we're very happy, I'm very happy to bring something back more cohesively on the impact that quality improvement has had. But those are small projects. What we're doing is embedding it into everyday practice, so it won't be just a training exercise. We're not doing the Six Sigma complicated, we're doing PDSAs, very simple approaches to QI, which are encouraging staff to test different things and to obviously then spread that. So going back to some real basics of QI, I think the more basic you keep QI, the better. So PDSAs with a good bit of data is probably all you need. The bigger lean Six Sigma, I think, we'll leave to other more complex folk. But as part of audit accreditation, it's really important that they're able to demonstrate that sort of improvement. But, we can quantify some of that and bring that back. But, actually some of the projects that have been delivered by this organisation are Wales leading, UK leading, and in some cases globally leading. I think what happened was, and James will correct me if I'm wrong, the previous approach under ABCI prior to the pandemic had been really well regarded. It was viewed as one of the best in Wales. I think it floundered in the pandemic, and what we're doing is refreshing and re-energising an approach that was here some years ago. So it's not that we've been trying it and it failed. I think we tried it. I think it was very successful, unless James tells me otherwise. Pandemic happened. It all went flat. What we're saying is we really, really need this now, because we've got too much harm happening in our hospitals, in our communities, and we need to find a way to manage that out.
Yeah, so sort of picking up on your point, Ewan, and sort of confirming what Jenny said at the outset of the sort of National Improvement Programme 2 years ago, we had a kind of an independent team come in and spend 2 days in the organisation interviewing multiple staff at the coalface, and they all talked about how it had been pre-COVID, and the assessment of the group was that we had a fantastic legacy from the ABC work that was done before COVID. But I think my reflection, and I discussed this with Leanne, Jenny, Peter, was that over COVID, everyone was so focused on the single goal that we lost our ability to do coalface quality improvement. And one of the issues we had post-COVID was our improvement activities were far too scattergun. But what we've done as part of this process is absolutely focus on what are the organisational priorities, and is ABCI, our improvement fund, working just on those priorities and not kind of side projects. And the mandatory training versus QI, they're not mutually exclusive. So one of the bits of mandatory training is recognition and response to deteriorating patient, which is probably a key factor in almost every SI we see. Ward staff who don't escalate in line with our policy. And that's not a problem you fix with a kind of e-module on ESR, because people know what to do. What QI gets at is why they're not doing it. It's about improving process reliability, using a sort of commercial term, and that's what QI is good at. And I was having a chat with the QI team yesterday because they had said they didn't want to work on something I'd suggested to them, and get a frank exchange of views around QI is good for process reliability. You don't have to be inventing something new when you're doing it. And we all, we're not discussing it today, but it is a constant theme, staff well-being. And it's hard if you're really busy to get your head into that space of, I want to make a change in my work environment. And that's where our ABCI coaching comes in. But as soon as people start doing it, they realise it's not very hard, and they realise that they can make huge change. And you see this really rapid improvement in performance across all areas, not just the area they're working in. And I think probably we talked about ENT today. The ENT ward was a problem ward when I arrived. Actually now you can't stop them. And it just started with a QI project.
Yeah, one of the things you find with this stuff, it's staff empowerment, rather than actual people don't know what the issue is.
Yeah,
it's actually giving them the power to do it. And what I'm sensing from a lot of this, there's a blocker in somewhere the staff don't feel empowered to get on with things.
So I think you're spot on, and this is a cultural piece, because the person who causes huge trouble in this organisation is someone. The staff tell us that someone told us we couldn't do this, and we can but they cause a lot of trouble, and part of that's the visibility that's coming out, staff going, why aren't you doing it?
And that's what I was going to say, part of it is missing out of here is how you're going to fix that someone, is how you're going to give that power into this process, rather than it being here's a project and it'll come all the way up, I guess you as the gets to Jenny, and before we can actually feed it back down again. And I think that to me is something that isn't quite clear in this report either, is how we get that empowerment going, that cultural change in the whole thing.
That's the conditions, it's the third C.
Yeah, it's going to be it's not going to be a battle, it's going to be a terrorist insurgency, the change in the culture. And one of the things that's in here is, I think it's the million minutes of coaching, which the ABCI team have committed to, and the way in which they're going to build up. But they're basically going to create an insurgency of people who are re-energised to do it.
Yeah.
So finally, sorry. Yeah.
So I just linked to that, but it is relevant. I think what we've not done in the past is link it to our priorities.
Yeah.
So lots of the programmes of work have been niche or have been very sort of specific. The guys have come to talk to me about how do we align these million minutes of coaching time to our priorities, because that's how we take it to embedding it in the organisation. And I think we do that. We've never done that before. I think we've never mapped it against the priority areas that we've got. And if we align those coaching minutes to our priority areas, it just becomes, I think, how we do things. I think we've got a better chance of success.
And our greatest areas of harm. You know, it's really important.
So what is the cost? What is the bottom line of this stuff? If we're coaching, you know, if we're training people, for example, presumably they have to be backfilled, or is this this be time that's already set aside?
Well, for nursing.
Because that's the piece of me that is really missing here, is what the cost of putting this in.
For nursing and health scientists, and well, actually there may be job planning in some of the therapy and health science. We don't set aside time. So doctors have time set aside, but it is, so I can't re-register as a nurse unless I have spent time completing CPD. I am required to spend a certain amount of hours in every 3-year period, and I have to evidence that. So it's part of my job. So although we haven't quantified it, I would consider it a part of a registrant's job to be able to evidence they've completed CPD training. And that will be a responsibility of management within nursing to make sure that's facilitated and that happens. It's less quantifiable than job planning because you don't have a set time, but there is a CPD element that is a requirement of all registration, no matter what your body is.
So none of this would be additional time?
No, I don't believe it is additional. It's a core part of the role. And actually it's built into ward accreditation as well, which we know from examples across the UK will deliver a change in terms of harm, which reduce costs. So it's that focus on how do we free people to reduce the harm, align with our priorities and to get on with the job.
So there is no additional cost for this?
No, I'm not going to come back with a begging bowl to say I need $500,000 to train all these staff. It will be part of a core responsibility.
David, you've waited a long time.
I have, and Ewan picked up quite a bit of where my concerns were. But I want to just say I absolutely agree that QI and quality improvement need to be a fundamental part of how we operate as an organisation. That is a bare minimum. Any sensible organisation, any good organisation needs to make it a fundamental part of how they operate and do that. Now, like Ewan, I've been here, I've done it, I've got the scars. Whether we're talking about Six Sigma, Lean, PDCA, Agile, Kaizen, 5S, TCM, I've done all of them. And the fundamental problem with all of these methodologies is they require dedicated time to be able to actually do the delivery and actually make the changes. And that means freeing people up to be able to do it and to be able to focus on it. Now, a lot of we've heard in every paper so far in this board meeting today that we are stretched. There is a huge amount that needs to be done. There are people, our clinicians and our non-clinicians are desperately trying to work on waiting lists and bring waiting lists down. They're trying to focus on really difficult problems. There's a huge amount of expectations from Welsh Government targets and the problems our patients have. I don't see how we are going to be able to free up people's time to be able to deliver this in a sensible way. Organisations that do this successfully have dedicated, set aside time to allow these projects to work, and that requires funding, that requires a cost. And what I'm really, really nervous about is saying that this is already part of the job, and so there's no cost involved. I think that's probably doomed to failure, and I really do think that we need to seriously consider how we create space, how we create permission, how we give people the dedicated time to focus on being able to improve quality. Because if you just make it part of the normal day job and just expect them to do it in the time they've already got available, it is always going to be the lowest priority thing on their list to do, particularly when they're having to deal with complex problems of patients, and when we're constantly throwing more and more targets at them and more patients at them to treat.
I think. Sorry.
Sarah, can you
please. Thank you.
Advise us on how much we actually get per nurse?
So there is already an uplift built into rosters for nursing in particular, for example, for CPD time. So that time is already built into our staff costs, and for other staff who are on 24/7 rosters in the main. Helpfully, in terms of supporting some of these points, most recently we've had to undertake a health board assessment of the time which is already set aside for CPD for a number of our professional groups. That's part of a All Wales piece of work which is looking at the non-pay collective agreement. We've been able to assess that and provide that on an All Wales basis. I can't recall the number off the top of my head, but we have been able to evidence that CPD time is happening for our staff out there. So the protected time is there to use. There will be conflict in terms of how we use that protected time, but in terms of having the strategy to provide a framework for how we use the time, linked in with other practical applications such as the ward accreditation that Jenny's mentioned, some of the work that's already going on out there, which Jenny's given us a good example of today as well. You know, there is that foundation there to help practically launch the strategy. And I was generally just going to make some other points, but I think Leanne and James have made them specifically around the opportunity here to use the people that we've already trained. The principles of QI, whilst not direct, but the principles remain in our leadership courses, and the impact that we know and we see that it has when we're out there meeting with our teams who are stretched but are doing this work and is having such a positive impact, I think is a really important concept to hold on to. And coming back to statutory and mandatory training, we are developing a paper based on previous discussions. It's almost ready, and I would imagine it'll be ready to come to board early in the new year.
Thank you. Pippa?
I mean, I'm very supportive of Jenny of quality improvement, and I think that it engages our staff because they want to do better. We don't have people who work here who don't care about what they do. And I think they always want to do better. But I just wanted to highlight something that we have had to board, but we've spoken about at PQSO, which is around never events, retained swabs, wrong site injections, which were quite a problem for the health board. And because of quality project that's been put in around human factor training, they have reduced to, well, I'm going to say, more than a year without an incident, but I don't know the exact figures.
It's in the report.
So, but it's, you know, the reality is that that these things make a difference, and the training for that must have been done in the day job. So I think this stuff is already going on, but it's just that for me, this feels like it formalises it a bit more, and as Leanne said, kind of brings some consistency across the health board. So that's there may be some things that we felt we wanted extra in the paper, but I'm very supportive of it in its entirety.
Anna?
Yeah, just really quickly, so absolute supportive of QI and just keen to, as we go forward, to work with Jenny and my team around how we then ensure, because we haven't signed off the organisational strategy yet, how that's mirrored in there and really the plan going forward. Leanne's point about aligning with priorities. So it's that kind of delivery and that detailed implementation that we can work together on.
Thank you. Well, I don't think sorry.
No, it's all right, sorry. We're in line with what Sarah was saying. I mean, with the non-pay agreement, it is set there that we're going to be embedding CPD time. A lot of professions already have that put in, as we've said. What we just need to do is make it an everyday thing and make it normalise it at the end of the day. We will see this quality improvement come out of it. Staff are really keen to make changes in the areas they work in. So I think we're just going to support this, but we've got to be really, really clear that people do have their CPD time, because that is what we're working towards from a All Wales perspective, collectively as a partnership, which includes obviously the trade unions as well. So we're on board with that, and we would expect from what you've just been saying, Jenny, that this should be a given throughout the organisation,
that we won't have to struggle to put this inside people's timetables to have their CPD time, to be able to contribute to this agenda.
Thank you. Oh, Penny.
Sorry, can I just say something? This has been a really interesting discussion, and so much more knowledge has come out of this discussion. We're all behind quality improvement, and I know about CPD from a nursing point of view, and it's absolutely vital. What I would request is that a kind of overview is put at the end, because so many positive things. If we prioritise this as the top thing, and all the others can come underneath, it's embedded. If it's truly embedded, then it will become just an everyday matter. So perhaps we could emphasise more in the report about the positives.
Can I suggest, Dan, what I'll do then is in the quality report that comes, we'll add a section on sort of QI successes and where we are with the approach.
Yeah, that'd be
because I think there's an element to this where we can't not afford to do it because of, you know, the harm that's occurring. But actually, we can draw the line between, you know, pressure ulcers is a really good example of action, collaborative pressure ulcer reduction. And therefore you get the, you know, we could start to quantify some of that, because there is there'll be evidence around releasing time to care, for example. So we'll start to draw that through in terms of our reporting, if that's possible.
Yeah, that'd be helpful. Thank you. Well, having listened to this very interesting discussion, I don't think I heard anybody who did not approve the principle of embedding QI principles within the organisation. Bearing in mind the whole issue of time, priority, outcomes. Right. So I think we'll note the progress that has been made. Thank you, Ewan. Note the progress of this initiative and how it's progressed so far. I think we're clear about actually the professional staff. The time is and the money is already built in, and it just means how to prioritise CPD. And if this is a real asset to do properly within this organisation, so that it's meaningful and really does produce the outcomes that are promised by it. And having put QI into my old trust, I know exactly what
I should have mentioned that.
Yeah, we had it. And we'll review progress along the lines that have been debated today in 6 months' time. Would everybody be happy with that? Yeah. Thank you very much.
Could I just add something?
Yes, carry on.
We've got Sarah very helpfully said we've got a discussion on training coming up at the next board meeting. Could we join this up? So we got QI, mandatory and statutory, and just to have that conversation about the holistic situation. Will that be helpful?
Yes.
Thanks so much.
I think Sarah wants to.
Yes.
I'm not keen to delay the statutory mandatory training paper though, so.
No, you carry on.
No.
To bring that and then I'll follow on.
Yeah.
Thank you.
Yeah.
Right, I'll just stop. I'm going to, I think I'm going to cause chaos and call an early lunch. I'm afraid there is something that Nicola and I need to deal with immediately. Thank you. Half an hour. Thank you.
Thank you.
Welcome back to the meeting of the Aneurin Bevan Health Board. And can we move now, please, to item 5.5, the Compassionate Leadership Pledge?
Thank you.
Thank you, Sarah.
So prior to the break, I think we were speaking about creating the right conditions for the quality and improvement work, and this paper links in quite succinctly into that conversation in terms of creating our compassionate leadership pledge. People around the table will be familiar with the compassionate leadership principles. Not so long ago, we had a development session with Michael West in relation to compassionate leadership and what that looks like in practice. And some of that information is contained in the background of the report for information and update. Chief executives and chairs have recently considered a compassionate leadership pledge, which has been put together by HIW, and across Wales have agreed that local organisations will adapt the pledge for local need and adopt it as part of a suite of measures in support of leadership and culture. So this pledge, as you'll see outlined in the paper on page 5 of the paper and 173 of the whole board papers, is how we've interpreted the HIW pledge for Aneurin Bevan University Health Board. The interpretation of that has been very much done on building on the programmes of work that we already